we can ask the questions. So if you have any questions for the first presenter, please note it down so that at the end of the presentation, you can go ahead and ask your question. Professor Yusufu is the next speaker. Professor Yusufu, welcome.
I perform better when I'm erect. Chief Medical Director, CMAC, my colleagues, our students, I've been asked to talk about breast cancer screening, the guidelines, barriers, and solutions. Next slide. You have to follow me. Yeah, breast cancer is the commonest cancer in women world over. I think Nigeria inclusive, Zaria inclusive. I will not talk more. We will not go into that politics. I know some people will want to crucify me after this lecture. In the US, it's the second cause of cancer death following lung cancer. The incidence is increasing in many parts of the world. It's common in the US, perhaps the UK, and least around Japan. In Africa, our problem is that it appears in women who are about 10 years younger when you compare, and then we appear to have the aggressive form. Next slide. So what is breast cancer screening? It simply means checking for cancer before symptoms and signs appear in the breast. If a woman has breast cancer and a lump, it is not screening. What you want to do, what you will do is to make a diagnosis and treat. Screening does not prevent breast cancer, but it finds it early, and then you may cure it. It aims to detect, treat cancer at an early age, at an early stage, when it is even most effective, that is treatment, and perhaps easier to treat. It is only then will breast cancer mortality reduce. Next slide, please. What are the screening tools available? Mammogram. The act of doing it is mammography. A breast MRI, clinical breast examination, breast self-examination, and breast ultrasound. I chose deliberately to put breast ultrasound below. A mammogram is a special X-ray of the breast. I'm sure the radiologist will tell us more about that. For now, it is the best way to detect breast cancer early at the moment. Mammogram. For now. The problem is that false positive results usually will lead to repeat mammograms. Perhaps you may have to move and do an MRI, breast MRI, and then usually also it will lead to unnecessary biopsies. And then you go and touch indolent cancers. These are cancers that otherwise would have not done anything to the woman. Breast MRI is used usually along with the mammogram. And then women at risk, it is done for women who are at high risk. Most of the women that are screened are average risk. Next slide. Clinical breast examination, this is done by a doctor or a trained nurse. And it should be done in the hospital. It can be done in the clinic, on the wards, or where you have a card and you can examine a patient. It aims to detect abnormalities in the breast. Usually lumps, skin changes, nipple areola changes, and axilla. So now if you do this, what it means is that we may get cancer at an early age and treat. But what mammogram does is that you detect abnormalities without a lump, and if you compare stage by stage, a mammogram is likely going to give you a result, a patient that you hope to get better results at the end. Next slide. Breast self-examination is what we teach or preach. And the problem is that most of us have not taken time to teach our patients how to do it. Every woman should be familiar with how her breasts look like and how they feel. Permit me to ask, spouses may also play a role in this place, so as to notice symptoms, usually lump, pain, or any changes, and immediately report such to a healthcare provider. Clinical breast examination and breast self-examination have not been found to lower the risk of dying from breast cancer. So we should make sure, we should know that. And women should be taught how to do this. The potential benefits of screening include: 1, reassurance for those who have negative results. Most women will have sleepless nights if they hear about breast cancer or a diagnosis of breast cancer is done. But if you do a mammogram and the result is negative, at least that woman can go to bed that night, sleep with her 2 eyes, and perhaps cook a good meal for her husband. The prognosis is improved, leading to fewer cancer deaths. You are likely to make a diagnosis at a lower stage, and then of course we expect a longer life expectancy after treatment. And if you get the disease at a lower age, treatment means it's going to be less extensive, and of course less expensive. Next slide. They are not without their hazards. False assurance for those with false negative results. Good. Anxiety and morbidity for those with positive results. This usually overdiagnosis also. Over-treatment of borderline abnormalities. And then hazards of screening. I'm sure the radiologists will tell us something about that. And cost, of course, is expensive. When you screen, what next? If you find something, you are going to make a diagnosis. If you make a diagnosis, you are going to investigate, and after that, you are going to treat the patient. Who bears the cost? Next slide. As far as breast cancer is concerned in Zaria, we have no guidelines. What people are practicing from experience and what they believe in. Good. But all over the world, particularly the US, many professional societies and organizations have guidelines. And these guidelines are evolving, and they are based on available evidences. And these are from randomized clinical trials. After that, they now make recommendations, which are subject to review every 2 years or thereafter. The tools for screening breast cancer are usually age-based, and emphasis on mammogram. Good. The United States Preventive Services Task Force, and then the American Cancer Society. This is just a table. The USPSTF says that women from 40 to 49 years at average risk. The decision to start is before 40. Before they are 50 years, is left to the individual who will place potential benefit over harm, and she may choose to begin biennial screening. What you are supposed to do as a physician is to give informed information. You inform the patient, then she will take a decision. Some patients may decide to start that for obvious reasons. While the American Cancer Society says that any woman who is 40 to 40 years at average risk should have the choice to start annual screening if she wishes. She will weigh the risk and benefits. But of course, usually they will need your guidance as a specialist. Next. From 50 to 74, with average risk, you should do it every 2 years on the US PTSF. While the ACS says at 50 to 54, with average risk, it is annual screening mammogram. If you are above 55 years and older, you should have it every 2 years. Next. 75 years or older with average risk, the correct evidence is insufficient to assess the benefits over the harm, over the balance of benefits and harms of screening. So what you guide you with your clinical decision on the patient and what the patient wants. The ACS says screening should continue as long as the woman is expected to live more than 10 years or longer. So some little differences, but they all have their reasons. I'm told that the recent WHO statistics for life expectancy in Nigeria is 56 and 54. Somehow women live longer than men. And so you see that, I'm not sure, but it doesn't matter. Let's go. Women with dense breasts And with the negative mammogram, the current evidence is insufficient also to assess the benefits and harms of others to others. Ultrasound, breast ultrasound may be done and MRI may be done. While the ACS says that women with breast on mammogram with negative mammo, there is insufficient evidence also to make recommendation for or against. So there is no evidence. The choice will be between you and the patient that is before you. Next. Good. So women at higher risk. When a parent, sibling or child has breast cancer, then the woman is at the higher risk of developing breast cancer. She may benefit more than the average woman from beginning screening at 40. And the reasons are simple. Her siblings have had breast cancer, or her parent or her child. The ACS also say that women at that, with the parent, sibling or child, and they have the BRCA1 and 2 gene mutation, should start MRI and a mammogram every year. They added MRI to the screening, and it should be done every year. Next. Fortunately, the American College of Obstetrician and Gynecology also have an input in this, because they also see women with breast. And their recommendation is that clinical breast examination in addition to mammogram should be done annually for any woman who is between 40 and 74 years. These are other organizations that also have input. The thing is extensive. In Zaria here, what we do, what guides us is the patient. And from our experience is that many women are afraid, I always use the word afraid, to appear to come for screening. They are probably not sure, not aware. I was told that when the mammogram machine was brought, they ran it for about a month and asked women, female hospital staff, to come for screening. If I remember my figures very well, there are about 3 doctors and 5 nurses. Please correct me. And that when you stand up. That's to tell you, free. And by that time, we had more than 3 nurses and 4 doctors, and so on and so forth. Next, please. What I considered are the barriers to breast cancer screening are: 1, ignorance. This is a problem all over the world, particularly in Nigeria. And if somebody is literate, he's likely to understand and is likely to heed to advice. So perhaps when we come to solutions, the people who are in charge will do that. Cost. Professor Samala asked the question, who will bear the cost? If you ask a woman to go and screen, except if you are doing a research study or some NGO or some foundation or some advocacy group is footing the bill, it's going to be out of pocket. I don't know what the cost is in Zaria, about 5K. It's more expensive in Kaduna. And I can tell you 5K is big money to many women in this country. Availability of equipped health services and trained personnel. Well, at a stage, it was thought that perhaps the country should be regionalized, as Dr. Samala suggested, so that you have these things in certain places available and accessible to the people with qualified personnel, so that we can offer services. Even at personalized screening, and maybe if you're going to do some community-based screening for people who are at risk. Fear of diagnosis. Yes, I've had this issue. I've spoken to some colleagues, to people, you are above 40. This is it. Why don't you come for mammogram? She says, doctor, why don't you let the sleeping dog lie? You know, what one told you was that what you don't know will not kill you, or something like that. Cultural beliefs, very, very rampant. It adds to our problem. 8 minutes of time. Okay, I'll round up. Fear of cultural beliefs. Some people believe that cancer should not be treated in the hospital. The actions of our traditional people also, who claim they can heal everything in this world. And then actions of faith healers these days also, they pray everything away and then do miracles to treat cancer and everything. Next. We need government to do something on education. It's only government that can take care of ignorance in this country. It's only government also, and some people who have money, perhaps philanthropists, that can provide well-equipped hospital and trained personnel for this. And then we need a lot of health education, which should be done at schools, markets, motor parks, worship places, wherever you have contact with people, through the mass media in all its forms. And I think all of us that are seated here have a role to play. Next. The cost of Medicare is prohibitive. Yes. What is the role of NHIS? I don't know, but I know in the UK and other places, most of it are borne by the insurance. It's not out-of-pocket expenses. Yes, next. Good, next. 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 Thank you.